Erythema multiforme is an acute, immune-mediated condition that affects skin and mucous membranes, like the mouth and genitals. The skin is the largest organ in our body, and it's divided into 3 layers: the epidermis, dermis, and hypodermis. The epidermis forms the thin outermost layer of skin. Underneath is the thicker dermis layer. And finally, there's the hypodermis, which is the deepest layer. The epidermis itself is made of multiple layers of developing keratinocytes, which are flat, pancake-shaped cells that are named for the keratin protein that they make. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of stem cells called basal cells that continually divide and produce new keratinocytes. These new keratinocytes then migrate upwards to form the other layers of the epidermis, like the spinous and granular cell layers. Below the epidermis is the basement membrane, which is a thin layer of delicate tissue containing collagen, laminins, and other proteins. Basal cells are attached to the basement membrane and help form the dermo-epidermal junction. Similar to how the skin lines the outside of the body, mucosa lines the inside of the body, and it's named for the surface it covers. So there's oral mucosa, nasal mucosa, bronchial mucosa, gastric mucosa, and so on. Mucosa is made up of 1 or more layers of epithelial cells that sit on top of a layer of connective tissue called lamina propria. Just like with the skin, there's a basement membrane that sits between and attaches the epithelial layer to the lamina propria. Now, basal epithelial cells, as well as most cells in the body, have a protein called major histocompatibility complex, or MHC class I molecule, on the surface of their membrane. This protein presents peptides from within the cell to immune cells called cytotoxic T cells. If a cytotoxic T cell recognizes the peptides as foreign, for example like in a virally infected cell, then the cytotoxic T cell will kill the presenting cell. Otherwise, if the cell is healthy and the cytotoxic T cell doesn't recognize the peptide as foreign, nothing happens. Erythema multiforme is a type 4 hypersensitivity reaction, meaning that the damage is caused when cytotoxic T cells inappropriately attack the basal epithelial cells. As part of the attack, the cytotoxic T cells release pro-inflammatory cytokines like interferon gamma and tumor necrosis factor alpha, which attract other immune cells to the area and cause more damage. And the result of all this damage is the formation of vesicles and erosions in the skin and mucosa. As the name suggests, erythema multiforme can appear in a variety of shapes and sizes. There can be macules, which are flat, red, or pink patches. There can be vesicles, which are small, raised, fluid-filled lesions. Or bullae, which are large, raised, fluid-filled lesions. There can also be papules, which are solid elevations containing no fluid. However, the most characteristic of all erythema multiforme lesions are targetoid lesions, which are between 2 mm and 2 cm, and have central necrosis of the epidermis, surrounded by concentric rings of erythema, making them look like a bullseye or target. Histologically, early on, there are a few lymphocytes near the dermo-epidermal junction. Over time, more inflammatory cells come to the area and are seen around blood vessels. Basal epithelial cells start undergoing necrosis, and subepithelial and intraepithelial vesicles start to appear. For a long time, it was believed that erythema multiforme was part of a spectrum starting with erythema minor on one end, and going to erythema major to Stevens-Johnson syndrome. And the most severe of all was the toxic epidermal necrolysis, or Lyell disease. However, Stevens-Johnson and toxic epidermal necrolysis are now considered totally separate diseases, and erythema multiforme now encompasses only erythema multiforme minor and major. So let's take a look at the differences between these two disorders. Erythema multiforme minor is a milder condition that's almost always triggered by a preceding infection. It causes targetoid lesions to form on the palms and soles, and the lesions are symmetric and typically spread toward the trunk. There's typically no or only mild mucosal involvement in erythema multiforme minor. In erythema multiforme major, 2 or more mucosal sites are involved, typically the oral mucosa and ocular or genital mucosa. And there are widespread skin lesions. So erythema multiforme major is more severe, but it's still only rarely life-threatening. The lesions in the oral mucosa are usually red patches that evolve into epithelial necrosis, leaving behind irregular, painful ulcerations that can bleed. These ulcers can happen anywhere in the oral mucosa, but most often involve the labial mucosa, buccal mucosa, tongue, floor of the mouth, and soft palate. It's very characteristic of oral erythema multiforme to cause hemorrhagic crusting of the vermilion zones of the lips. Erythema multiforme is most commonly associated with a preceding mycoplasma or herpes simplex virus infection. Some patients can have recurrent episodes of erythema multiforme, especially in the oral mucosa, due to herpes simplex virus type 1 or less commonly type 2. It's thought that the herpes simplex virus proteins are similar to proteins found in the oral mucosa, causing the T cells to get confused and attack keratinocytes expressing those proteins. Erythema multiforme can also be caused by medications, including penicillins, sulfonamides, ciprofloxacin, and anticonvulsants, like phenytoin and carbamazepine. In comparison to erythema multiforme, Stevens-Johnson syndrome and toxic epidermal necrolysis are almost always due to a drug reaction, and involve much more of the skin and mucosa, and are much more life-threatening. The diagnosis of erythema multiforme is based on the classic skin rash with a targetoid appearance along with the hemorrhagic crusting of the lips. The involvement of the oral mucosa makes it hard for a person to eat and drink, leading to dehydration. So part of the treatment is maintaining good hydration, which might include IV rehydration as well as pain control. If there's an underlying cause, it should be dealt with. For example, an infection should be treated and an offending medication should be stopped. Systemic corticosteroids can be used to help reduce inflammation. The good news is that the process generally self-resolves over weeks. In cases of recurrent bouts of erythema multiforme due to herpes simplex virus, continuous oral acyclovir or valacyclovir can be used for prevention. Alright, as a quick recap. Erythema multiforme is a derangement of the immune cells that start attacking epithelial cells, and that is usually triggered by an infection like herpes simplex virus or medications. Erythema multiforme minor affects only a limited region of the skin, and one type of mucosa, usually the oral mucosa. Erythema multiforme major causes widespread skin lesions, and affects 2 or more mucosal sites. Both types can cause a skin rash that characteristically might have a targetoid appearance and bleeding, as well as crusted lips, and should be treated with systemic corticosteroids and elimination of the triggering factor.
Stevens-Johnson syndrome is named for the physicians who first reported an acute immune-mediated condition that affects the skin and mucous membranes such as the mouth and genitals. Stevens-Johnson syndrome and toxic epidermal necrolysis are considered to be the same condition, but are along a spectrum where toxic epidermal necrolysis is the more severe form. Both can be fatal if not treated, and the risk of fatality increases with severity. The skin plays an important role in protecting underlying muscles, bones, ligaments, and internal organs by forming a barrier to infectious pathogens and preventing water loss from the body. The outermost layer of the skin is the epidermis, and itself is made of several layers of cells. The deepest layer is called the stratum basale, or the base layer. And the cells here are anchored to a basement membrane, a thin layer of dedicated tissue containing proteins like collagen and laminins, which attach to the epidermis to the underlying skin layer called the dermis. Similar to how the skin lines the outside of the body, mucous membranes, or mucosa, line inner body surfaces like the mouth, tongue, respiratory tract, conjunctiva of the eyes, genitals, and anus. Mucosa is made up of one or more layers of epithelial cells, which, again, are attached to a basement membrane that sits on top of a layer called the lamina propria. Now, most cells in the body have a protein called major histocompatibility complex, or MHC class I molecule, on the surface of their membrane. This protein presents peptides from within the cell to immune cells called cytotoxic T cells, also called CD8 plus T cell. If the cell is healthy, the cytotoxic T cell doesn't recognize the peptide as foreign, and nothing happens. But if a cell is infected, say, with a virus, the cytotoxic T cell can recognize the peptides as foreign and trigger an immune response. Once all infected cells have been destroyed, the immune response resolves. Stevens-Johnson syndrome and toxic epidermal necrolysis are both type 4 hypersensitivity reactions. They're also called T-cell-mediated hypersensitivity reactions because cytotoxic T cells directly and aggressively attack the epithelial cells in the mucosa and the epidermis, and release a payload of perforin and granzymes to kill them. Perforin lyses the target epithelial cell, forming pores which allow granzymes to enter and induce cell death or necrosis. Also, as part of the attack, the cytotoxic T cells release pro-inflammatory cytokines like interferon gamma and tumor necrosis factor alpha, which attract other immune cells to the area that cause even more damage. This leads to a loss of the skin barrier protection and erosion of the affected skin and mucosa from cellular death and detachment at the basement membrane. With the skin and mucosa compromised, the body can dehydrate, and pathogens from outside the body can invade and cause an infection, which can lead to another strong immunologic response called sepsis that can cause large-scale tissue and organ injury and dysfunction. Stevens-Johnson syndrome and toxic epidermal necrolysis are considered variations on the same skin condition. Previously, erythema multiforme had been on the same spectrum as Stevens-Johnson syndrome and toxic epidermal necrolysis, but now, erythema multiforme is considered its own skin condition. Stevens-Johnson syndrome and toxic epidermal necrolysis differ from each other by the percent of body surface area that's affected. So, if 10% of the body's surface is affected, it's considered Stevens-Johnson syndrome. If 10 to 30% is affected, it's considered an overlap between Stevens-Johnson syndrome and toxic epidermal necrolysis. And if above 30% is affected, it's considered toxic epidermal necrolysis. Triggers for the type 4 hypersensitivity reaction in Stevens-Johnson syndrome and toxic epidermal necrolysis are typically certain kinds of medications whose metabolite peptides are recognized as foreign by the cytotoxic T cells. Examples are some anticonvulsants like carbamazepine, some antibiotics like sulfonamides, some immune modulators like nevirapine and sulfasalazine, and some NSAIDs like piroxicam. In addition, some types of infections like Mycoplasma pneumoniae or cytomegalovirus can also be a trigger. Two distinguishing symptoms of Stevens-Johnson syndrome and toxic epidermal necrolysis from other similar conditions are that both mucosal linings and the skin are affected, and these conditions present with a fever because of the cytokines released during the immune response. Early on, there may be flu-like symptoms like a sore throat, cough, red eyes, and a tender pink skin. Eventually, the rash progresses to having a dark red center, and a variety of lesions appear that might develop from flat macules to fluid-filled vesicles and large bullae. Finally, as necrosis occurs, the affected skin and mucosal lining can begin to detach and slough off, leaving the area looking like it's been severely burned. Slightly rubbing the lesion may also cause the outer layer to fall off, and this is called the Nikolsky sign. A clinical diagnosis is typically made based on symptoms, but a biopsy of the affected area can help make a definitive diagnosis. Treatment typically includes hospitalization, particularly in a burn or intensive care unit for severe cases. Triggering medications should immediately be stopped, and treatment should begin to treat a triggering infection. Systemic immune modulators like antihistamines, intravenous immunoglobulins or IVIG, or corticosteroids may be used to suppress the hypersensitivity response. And supportive therapy with pain medication, hydration, and sterile wound care can help prevent further complications. After healing, there can sometimes be scarring. So, to recap, Stevens-Johnson syndrome and toxic epidermal necrolysis are acute, potentially fatal type 4 hypersensitivity reactions where cytotoxic T cells inappropriately attack and kill epithelial cells in the mucosa and skin epidermis. If 10% of the body surface is affected, it's generally considered Stevens-Johnson syndrome. If above 30% is affected, it's considered toxic epidermal necrolysis. The most common trigger is some types of medication, and treatment includes immediately removing the trigger followed by supportive therapy.